Good morning and welcome everyone to the Spokane Regional Crisis Collaborative meeting. I'm Kellen Roy with the Spokane County Regional Behavioral Health ASO, and I will be facilitating the meeting today. For anyone that is new to this meeting, thank you for joining us. We're glad you're here. Just a quick overview of the purpose of the SRCC. This meeting is held on a quarterly basis and allows for local stakeholders, community members, treatment providers, managed care organizations, law enforcement, tribes, and other emergency services to come together and be able to staff and discuss all topics related to our behavioral health crisis system, which covers our BHASO 6-county region, Spokane, Adams, Pend Oreille, Stevens, Ferry, and Lincoln counties. It also provides the opportunity to share information on new programs, identify any challenges or trends, and develop solutions for common goals throughout our region. So with that, for today's attendance, I'm going to ask if everyone can please put your name, title, and agency in the meeting chat so we can keep track of everyone who is in attendance. And with that, we'll go ahead and jump into our first agenda item. We have Haley Jo Scythe, Assistant Director at Pioneer Human Services, today to provide an overview of the Spokane Regional Stabilization Center. So Haley Jo, I'll turn it over to you.
Wonderful. Thank you so much. Hi, everyone. My name is Haley Jo. I appreciate your time today and allowing us to present on our program. I also have with me Tennille Lightfoot. She is our Regional Director that oversees the Stabilization Center as well as Pioneer Center East. I'm going to go ahead and take a second to share my screen here. And all right, can everyone see that okay?
Yep.
All right, so Spokane Regional Stabilization Center is a 3-in-1 program. We were originally developed as the first pre-booking jail alternative in Spokane, Washington. Originally, we were exclusive to law enforcement and criminal justice agencies. Since that time, although we still prioritize criminal justice agencies and law enforcement, we have expanded to referrals from behavioral health, hospitals, medical centers, as well as a self-referral basis. We are mainly Medicaid funded. We do take Kaiser Permanente, as well as working really closely with the Spokane ASO for qualifying individuals. So the programs within the facility are mental health crisis stabilization, medically monitored withdrawal management, 3.7 level of care, as well as a co-occurring mental health and substance use disorder residential inpatient, or 3.5 level of care. So we'll go ahead and just start with our mental health crisis stabilization program. So it's a 16-bed program. Individuals generally stay with us from a 3 to 10 day time span, depending on level of acuity. Individuals that we serve are generally experiencing significant mental health crisis, whether that's significant suicidal ideation or potential mental health diagnosis that their symptoms are currently impeding their daily level of functioning. And so staffing in this program are psychiatric ARNPs that work on medication management, and they provide assessments within 24-hour time frame, comprehensive case management for individuals to help them essentially do a needs assessment in the door, and they're able to connect them with services outside of the program once the stabilization is complete. We also provide individual treatment planning, mental health therapy, and group programming. Does anybody have any questions about the mental health crisis stabilization program before we move forward?
What age range do you take?
We are 18 and over, so we focus on adults.
Thank you.
You're very welcome. All right, if we have no other questions, I'll go ahead and move over to our withdrawal management program. It is a 14-bed facility. We do utilize 24/7 nurse monitoring. We have house stock withdrawal medications in-house, and so there is no need to go to the hospital prior to entry into the program. Individuals receive a nursing assessment, a detox assessment from a substance use disorder professional at intake. and able to identify criteria as well as medical necessity. It is generally a 3 to 5 residential stay depending on symptoms and level of acuity. And each client will receive SUDP counseling, group programming, that comprehensive case management, as well as individualized treatment planning. There are a few exclusion criteria with our withdrawal management because of our staffing with medical ARNPs. We're able to do a lot of the medical clearance in-house, which really reduces the amount of individuals need to send to the hospital for medical clearance. But we aren't at this time able to accommodate benzodiazepine withdrawal, or we're able to take methadone in-house, and we're able to transport to methadone clinics essentially for daily or weekly dosing. But if the individual is utilizing illicit methadone, because of the properties of that, we are unable to accommodate a detox from that at this time.
Haley Joe, real quick, just realized the slides aren't moving. We're still on the title slide. I'm not sure if that's on your end or.
Let me.
There we go.
Okay.
Yeah.
I see here. The slideshow went to a different, I'm going to go ahead and try to reshare my screen.
Not a problem. We're happy to email this PowerPoint out afterwards if that's helpful.
Absolutely. All right, it won't let me. Are you able to see that?
Yep.
Perfect. Are there any other questions about our withdrawal management program? All right, I'll go ahead and move forward. So the third program within the facility is as our 3.5 level of care co-occurring residential inpatient. This program is also a 16-bed program. Essentially, it's a 28-day stay. 28-day stay is in parentheses because it's all based on medical necessity and need for extended treatment. And so if an individual needs additional days in treatment, we're able to assess that towards the end and really work with them for those extended stays if needed. We provide substance use disorder group therapy 7 days a week, mental health group therapy 5 days a week, ARNP medication management and monitoring. We provide marriage and family therapy within the facility for our co-occurring clients, as well as that comprehensive case management. Additional services provided within all 3 of the programs include lab and blood testing, STI testing, pregnancy testing, mental health assessments, substance use disorder assessments. We also recently partner with Consistent Care to provide HIV, Hep C, syphilis testing while in treatment, as well as referrals to follow treatment. They start the treatment while they're in care with us, and Consistent Care will follow them into the community to continue treatment after they leave our program. We provide daily or weekly transportation to methadone dosing, long-acting injectables for mental health, and medication-assisted treatment for substance use disorders. We provide FCS peer bridging and housing specialists that follow the individuals into the community after they leave our program. They also have access to a multidisciplinary team to address medical, mental health, and substance use disorder needs simultaneously, peer services and counseling, as well as primary care referrals. So let's talk a little bit about the referral process. We do take 24/7 referrals, and so we are open 24/7. And so if an individual is looking for access to care in the middle of the night, we are able to accommodate that as well too. Every client that is interested in services with us does have to complete a phone screening. This is a small interview over the phone to identify medical necessity and criteria. This does look a little bit different for hospital referrals and law enforcement referrals. For hospital referrals, because of the potential for higher medical acuity, we do ask for some documentation and a nurse-to-nurse interview prior to entry. Law enforcement referrals for ease of access. Essentially, they will provide general demographic information, and we really work on the individuals coming in from the community, dropping them off within a 5-minute time frame, and then being able to go back into the community for the rest of their day. We also take self-referrals and walk-ups to the agency. This is a small view of the phone screen that we are utilizing. We recently changed this from a paper phone screening to a screening in our EHR, but initially we would ask the client's name, general demographic information, and information regarding their substance use history, as well as mental health diagnosis, to identify which program would best meet their needs. Additional referral sources from the quarter of 2024, we received referrals from Sober Centers Detox, residential facilities, probation, law enforcement agencies, hospitals, self-referrals, family of friend, DSHS, court, corrections, community mental health agencies, as well as community substance use disorder providers. This is some feedback that we received from clients. We really like to celebrate client successes, and clean time. We've had a lot of individuals reach back out to us and look for employment, which has been wonderful as of recently. But I'll just take a second to leave this up. I won't read this one verbatim. Does anybody have any questions?
There was a question in the chat from Gail Kogel asking, is this a Spokane or for Spokane County only, or can it be from residents from outlying counties as well?
It's regional, and so we take individuals from Walla Walla. We've accommodated individuals from Seattle and all surrounding areas.
I just have a question for clarification. We've been getting this is Stacy, some referrals, and it says that they've run out of benefits. And I was just curious, how do benefits get set up for them? How's the length of stay decided?
Absolutely. And I think we had spoken a little recently regarding that. I think the communication may have been off depending on who had reached out to you. And so essentially for individuals in our stabilization program, it is a 3 to 5 to 7 day stay. We do work really closely with the MCOs to identify medical necessity and extended stays. As of recently, it really depends on the symptoms that they're experiencing, whether they're harm to themselves, as well as the significant symptoms that they're experiencing.
So if they are if their benefits have worn out, but they still are, or ran out, but they still are suicidal stuff, can they be referred to a higher level of care with their benefits, or like for a voluntary admit?
Yes.
Okay, thanks.
You're very welcome.
There's never really any guarantee of benefits. So that it may be due to different factors. You know, they may have reached a maximum benefit amount depending on what their MCO is, or the MCO may be saying that they don't meet medical necessity anymore. So there could be different reasons why that is. But we would do our best to refer to wherever they could receive services. But again, there's no guarantee. So I just wanted to put that out there.
Excellent. Any other questions for Haley Jo or Tennille? Hearing none, not seeing anything additional in the chat. Well, awesome. We appreciate you both being here today and sharing about the SRSC. As mentioned, we'll be happy to send this slideshow out. And if anybody has questions, reach out to Haley Jo and Tennille.
Thank you so much.
All right. Getting back to our agenda. Next up, we have Crisis Dispatch Protocols Review. Ashley, Jessica, and myself. Leah, if you can queue up the slide deck, that would be helpful. And Ashley, I will let you introduce yourself and turn it over to you.
Thank you, Kaylin. Good morning, everyone. Thank you to Neil and Haley Joe for that presentation on the SRSC. Today, it looks like our slideshow went away. I think Jessica is the one pulling that up. Thank you, Jessica. Today, at our last Crisis Collaborative, we talked a little bit about dispatch protocols, something that we have been actively working on within our region. And so I am going to be starting us off with kind of a review of that today for this group. Go ahead and go next slide, please. And I'm Ashley McGee. I'm the Integrated Behavioral Health Manager here for our Spokane Regional BHASO. So a little bit of background on what the regional dispatch protocols are. And this came out of Senate Bill 6251, which established that BHASOs would use their authorities to establish coordination within the regional behavioral health crisis response system, included to developing comprehensive protocols dispatching mobile rapid response teams and community-based crisis teams. So really this is fitting in with the state's crisis system redesign. There's been a lot of work, a lot of components that have been incorporated over the last several years with different statutes, 1134, 1515, Senate Bill 6251, with 988 coming into Washington State and providing that prevalent role. There's been other incorporations of parts of that system as we move forward. And part of that is endorsed mobile rapid response and community-based crisis teams. And with that coming along, these dispatch protocols is really to take a look at our entire overview of our crisis response system and work out how those dispatching and how those parts are coming together to ensure that that crisis continuum is full for individuals receiving care. And so some of the things that those dispatch protocols go over is an overview of our crisis response system, what crisis services and the locations of which those are provided at, dispatch workflow, and this is particularly important when it comes to endorsed teams, which we'll talk a little bit more about as we move through this presentation. Admission to facilities and transportations. This pertains mainly to what facilities do we have within the region that individuals can receive services at, and then for transportation, which I know is always a challenge across the state and definitely in our region as well. This pertains more significantly to the endorsed teams as well, because there is a transportation component of that. For non-emergency requests, this pertains to if someone is calling the RCL or 988 and looking for services, and maybe it's not an emergency request, maybe it's someone who's enrolled with PACT or WISE or IRT, how do we refer them back to those providers and get them connected? And then of course, coordination with our managed care organizations. So ensuring that as we oversee the crisis system of care, that we're coordinating on the front and back end with our managed care organizations to ensure individuals and members are getting connected to ongoing services and needs met when it comes to their medical or outpatient behavioral health or inpatient behavioral health needs moving through the crisis system. Next slide, please. And I think I'm turning that over to Kaylin.
All right. Yeah, moving on to our next slide, which includes some of the newer and existing behavioral health crisis definitions. The Spokane Regional Crisis Hotline, also commonly referred to as the RCL, which is a designated telephone service covering our 6-county BHASO region. Currently, the RCL is being operated by Frontier Behavioral Health. Incoming calls are answered by a live voice available 24 hours a day, 7 days a week. Many times this may be the first contact or entry point for an individual experiencing a crisis. So RCL staff are trained to provide crisis screening, triage, and make referrals as needed. Crisis Response Triage and Mobile Dispatch Coordination Unit, or MDU. This is the unit responsible for receiving and reviewing crisis information, determining which crisis resource is most appropriate and should be involved in the response. They have the ability to make referrals, which often could include call outs for mobile crisis responders, DCRs for RTA investigations, endorsed teams, co-responders or co-deploy units, 911 dispatch, and or other community providers as needed. Mobile Rapid Response Crisis Teams. This is a team that provides community-based outreach, interventions, de-escalation, stabilization, and resource connection for individuals experiencing a behavioral health crisis. Based on best practices and staff availability, these teams should include certified peer counselors or certified peer support specialists, as well as meeting standards for response time set by the authority. Moving on to community-based crisis teams. This is a team that is part of an emergency medical service agency. Could be a fire department, a public agency, public health agency, a nonprofit crisis response provider, or a city, county government entity other than law enforcement that provides the on-site community-based intervention of a mobile rapid response crisis team for individuals experiencing behavioral health crisis. And lastly, DCR, or designated crisis responder, which is a mental health professional with specified training, has been designated by the county or other authorized entity to be able to perform Involuntary Treatment Act evaluations and civil commitment duties described in RCW 7105 and 7134 as it pertains to youth. DCRs have the ability to involuntarily detain individuals up to 120 hours if they meet certain risk criteria. Next slide, please, Jessica. This next slide provides a general overview of Spokane Regional Behavioral Health Crisis Response System. Our crisis response services are available 24 hours a day, 7 days a week, 365 days per year to all individuals within our 6-county regional service area, which again includes Adams, Ferry, Lincoln, Stevens, Pend Oreille, and Spokane counties. Behavioral health crisis services cover a wide spectrum and are provided to individuals experiencing a mental health and/or substance use need, specifically intervening when a behavioral health issue is impacting the individual's safety, well-being, and/or functioning. The slide also lists out the crisis services that are available, which includes walk-in services during regular business hours, mobile rapid response crisis team, Involuntary Treatment Act for DCR investigations, short-term stabilization services, which includes mental health crisis stabilization, sobering, withdrawal management, similar to the SRCC that Tennille and Haley Jo were sharing about, as well as Spokane Regional Crisis Line, RCL, and MDU. So when an individual's stability or functioning is disrupted, crisis services provide immediate and short-term interventions aimed at helping individuals resolve the situation, hoping to prevent further deterioration and stabilize so that a higher level of care is no longer needed. Really, the goal and intent of crisis services is to provide immediate treatment and intervention in a location best suited to meet the needs of the individual, as well as provide treatment in a least restrictive environment as possible or available. And unlike other services, all crisis behavioral health services, including ITA services, can be provided without an intake, evaluation, or screening. Next slide, and I think I'm turning it over to you, Jessica.
Wonderful. Thank you so much, Keelan. We created this slide to highlight the partnerships and roles that are involved with the behavioral health crisis response system, as well as to illustrate the flow of funding for the behavioral health crisis system and the services provided under that. As many of you know, that starts at a state level. HCA provides funding to both the ASOs and managed care organizations to provide oversight of the behavioral health crisis system. And then a caveat of that is the Department of Health contracts directly with Frontier Behavioral Health to provide the 988 service. And digging in deeper, so from HCA, the funding flows down to the BHASO, so our organization, to provide oversight of the Spokane County Regional Service Area Behavioral Health Crisis System. In that work, we partner with managed care organizations who delegate behavioral health crisis services for their members to the ASO. So those are Medicaid members, so that we can continue to provide oversight of, MCOs still continue to provide oversight of both medical and non-crisis behavioral health services for their members outside of the crisis system. And that is done through the model of integrated managed care. So in moving back to the crisis system, again, the MCOs delegate the behavioral health crisis system oversight work to the Spokane County Regional BHASO. And through that efforts, we are in constant communication with the managed care organizations to ensure care coordination and quality of services for the individuals within our regional service area. What that kind of looks like on a day-to-day basis is we send daily crisis logs to our MCO partners, as well as monthly high utilizer reports related to their members, so we can provide care coordination and follow-up for those individuals that are in need. Additionally, the Spokane County Regional BHASO contracts with many of you on this phone call today to provide those behavioral health crisis services, and Kaylin just gave an overview of what those are. But in Pend Oreille County, we contract with Pend Oreille County Counseling Services. In Adams County, that's Adams County Integrated Healthcare Services. For Stevens, Ferry, and Lincoln counties, that's Northeast Alliance Washington Behavioral Health. And in Spokane County, we contract with Frontier Behavioral Health for those services. Move on, don't have to say next slide because I get to click the slide. So this next slide is to highlight the partnerships that are involved with ensuring the crisis response system is effective in meeting the needs of our community. And a big part of that is coordination between 988, 911, first responders, and our crisis teams. In Spokane County, we do have Frontier Behavioral Health, as noted before, is our crisis provider within Spokane County, and they do operate and they have a business associate agreement, BAA, with the local PSAP to coordinate response with first responders and the behavioral health crisis system. This partnership allows first responders and the crisis system to dispatch the appropriate team for the situation, and those situations vary. This partnership also assists in diverting calls to 988 that don't need a law enforcement level of response or do not need that any other first responder response, and ensuring the individual is getting the appropriate care for their behavioral health need, and that is given by behavioral health professionals. In line with that, we wanted to share a little bit about behavioral health co-response programs within our region. Just as a refresher, these services are intended to provide an integrated response in conjunction with municipal or county law enforcement, fire, or emergency medical responders that can respond to individuals with complex behavioral health and physical health needs, depending upon the situation. We do have a few teams in Spokane County specifically that are standing and operating currently. And these include the Behavioral Health Response Unit, which is a Frontier Behavioral Health clinician paired with a Spokane City Fire Department paramedic. We also have the Behavioral Health Unit, again, Frontier Behavioral Health clinician, but this time paired with both Spokane County and Spokane City law enforcement officers. And then the Community Diversion Unit, that is operated by through Frontier Behavioral Health clinicians paired with Spokane City law enforcement officers. So we also do have other more informal things that go on within our rural counties to support behavioral health co-response type services. And it is of note that, as many of you know, mobile rapid response teams, as well as designated crisis responders, may respond with law enforcement, depending upon the situation and any safety concerns that arise to ensure, safety for our responders as well as the individual experiencing a crisis. And this is outside of those crisis teams. This is something that happens on an ongoing basis, depending upon the need. Continuing on with other partnerships and that allow for our crisis system to operate and operate effectively. We have many different partnerships within our region that range from both formal to informal partnerships with certain entities to ensure that we are operating a quality behavioral health crisis system for our members within the Spokane Regional Service Area. Some of these partnerships include, as we just spoke about before, partnerships with law enforcement and first responders. And a lot of these are, again, we have some formal agreements, but also some informal agreements for when that co-response or dual response is needed. Another partnership that is key is a partnership with Spokane County Regional Emergency Communications, SRCC, which is our local PSAP. And in Spokane County, Frontier Behavioral Health, as mentioned before, does have a BAA with SRCC, so which operates the local safety answering point. We also have hospitals and psychiatric inpatient facilities, lots of partnerships within those. So all crisis providers within our Spokane RSA have informal agreements with hospitals within their area to allow for coordination for both voluntary and involuntary behavioral health crisis services. We also have both some informal and formal agreements with our tribes within our region. Plans and protocols, these plans and protocols are developed and agreed upon by the Healthcare Authority and tribe or non-tribal Indian healthcare providers with input from the BHASOs and crisis providers to allow for care coordination, discharge transition planning, and other needs of tribal members as they arise. These plans are continuing to be developed within the Spokane Regional Service Area, and this also ensures ongoing communication and collaboration with local tribes so we can best meet the needs of tribal members and discuss any changes, strengths, or challenges within the crisis system as they arise. There's also informal partnerships with jails. All crisis providers in the Spokane Regional Service Area have informal agreements with our jails to allow for coordination of crisis response services and involuntary treatment act evaluations within the jail setting. So lots of partnerships that make our crisis system go around and are necessary. And then I'm going to turn it back over to you, Ashley, and I get to stop talking. And so this slide is next for you.
Thanks, Jessica. Okay, so as we review kind of our crisis system of care, we put together a little visual, and this visual incorporates kind of how things stand now and the future vision of some of the components of our crisis system. So last crisis coordination meeting, we talked a little bit about a joint policy statement that was released by the Department of Health as well as the Healthcare Authority in regards to the future state of 988 and RCLs, and really envisioning 988 as that central entry point for help seekers, and then the RCL, the future state of the RCL to be more envisioned for professionals and dispatching and deployment of our mobile rapid response crisis teams, our mobile teams, DCRs, our crisis response services when an in-person response is needed and requested. And so this visual kind of puts together a little bit about what that workflow looks like, as you can see, designating the help seeker and then also professionals, and how we envision that to look and how we are transitioning into that currently through a tiered process in phase 1 of that. So an individual can call into the 988 line or the RCL line, and at times those calls can be resolved over the phone to have crisis resolution in connection to ongoing services. And at times an in-person response may be needed. And when that happens, the plan is to transfer those individuals to the mobile dispatch unit, who acts as a central hub for triaging incoming behavioral health crisis calls and really helps determine the most appropriate mobile team to dispatch in real time. And so looking at things like acuity, availability, and location, taking that pressure and reliance off of those call line services so that they can get back to the next call and not have to make those determinations and have a more specialized team that has that knowledge and information and connection with those crisis teams to be able to dispatch more appropriately and streamline that process. We're very lucky in the Spokane region that we have vertical integration currently, with Frontier being both the 988 and RCL provider. So it allows us a unique opportunity to really start the transition earlier than other regions across the state, and to avoid duplication of services and streamline that approach. Of course, that mobile dispatch unit may gather additional details about location, safety, to help our crisis teams be prepared for responding in the community, which, as you can see, the person running out the door, our crisis teams get out the door to go respond to the individual in crisis, whether that be in the community, in the hospital, in a facility, in a jail, can just depend, in a school. And through that assessment and intervention, that can have multiple different outcomes that could lead to crisis crisis resolution in connection to ongoing services. That could lead to voluntary short-term crisis stabilization and hospitalization. That could also lead to the involuntary treatment services if needed, all with the hope of that individual returning back to the community post-discharge with appropriate supports. Next slide, please. This is just a list of our crisis providers, their addresses, their hours of operation for their crisis services, and their just main contact numbers for their agencies. Next slide, please. This slide, so as Sam says, best practice guides for crisis, it consists of 3 different components: someone to call, someone to respond, and a place to go. And so we wanted to kind of identify that within our own regional crisis system. And so someone to call, currently, as we've discussed, we have 988, who is envisioned as the future state for help seekers entry point into the crisis system. We also have the regional crisis hotline, which Caitlin gave a little bit of information. That's also operated by Frontier Behavioral Health, which is a 24/7 crisis line that provides services and also dispatch and deployment of crisis teams. And then we have the Crisis Response Triage and Mobile Dispatch Coordination Unit, also known as the MDU, which we're in kind of that phase 1 of onboarding that team in to streamline that approach. Right now, you can call any of the numbers, the 988 or the regional crisis line, and you will still get the same response. It doesn't matter which number you call, a response will be provided. But in the future, we will be looking at, incorporating another number for professionals to access directly to the mobile dispatch unit, so they don't have to go through the 988 prompt when looking to access response in the community for an individual. Next slide, please. Then we have someone to respond. So again, kind of going back to the purpose and intent of the dispatch protocols was the incorporation of the different components, as Jessica kind of described. We've got DOH, we've got the healthcare authority, we have the crisis system as it's currently funded, and then we have the new addition of these endorsed teams. So what does that mean? What are these teams and what are they doing? So these teams were established by House Bill 1134, one of those bills that we mentioned earlier, to create endorsements for mobile rapid response teams and community-based crisis teams to maintain capacity to respond to in-person to individuals experiencing a significant behavioral health emergency that requires an urgent in-person response that doesn't require a law enforcement response. And so someone calls 988 and it's identified that they need that behavioral health emergency response, which is defined later down in the slide here, a person experiencing a significant behavioral health crisis that requires an immediate in-person response due to the level of risk or lack of means for safety planning as defined in the WAC, which kind of that WAC provides the outline and overview for these endorsed teams and what is required for those teams. And so a little bit ambiguous, and we're still working on kind of how that's going to look in our system of care. We don't have any endorsed teams in our system of care right now, in our crisis response system. That is new. That just application process was in December and January. And so looking to the incorporation of that within our system of care and a statewide, it's a voluntary process, so teams are not required, existing teams are not required to be endorsed, and community-based crisis teams, which is a new team designation that was created out of this House bill, are also not required to be endorsed. However, if they seek endorsement, it pulls them into that crisis system and kind of incorporates them in under the BHSO contracting into that crisis system for response. And there's also additional benefits that they can receive from that. If they meet the statutory time requirements for response, then they can get additional performance payments. And so there is some incentive for teams to do that, but there's a lot of different components. Again, that's prioritized for response to significant crises, and can open some of the opportunity for 988 funding as it's part of the 988 system for those teams to operate and respond in that way. So what are those requirements? There's staffing requirements, training requirements, and transportation equipment and communication standards. Those are all listed out in that WAC. The staffing consists of 24/7 staffing. the training. There's certain trainings that need to be completed within 90 days, within 180 days, and ongoing. And then there are certain requirements as it pertains to transportation, equipment, and communication standards. The transportation, that's something that we talked about on that first slide. So teams must be capable of providing transportation to individuals when clinically appropriate to transport them voluntarily to a behavioral health receiving center if appropriate. And so that is a component that's being built into these endorsed teams. We're still working through kind of what that looks like. And again, that's within clinical discretion because we want everyone to be safe during that, but there are also standards regarding what those vehicles need to be equipped with and how they are equipped to allow for safety for the individual and the crisis teams if transporting. So we talked about the behavioral health emergency there and the difference between MRCT, which some people refer to as MERCAT. I don't know if that's easier or not. It's a long acronym. And then the CBCTs. So mobile rapid response crisis teams, these are teams that are operated by a behavioral health agency and consist of behavioral health staff, clinicians, and peers supervised by a mental health professional. Again, as Kaylin kind of mentioned, the ideal model is a clinician and a peer responding jointly in the community. However, that's based and dependent upon availability of staffing, which may look different depending in what county in our region someone is operating from. Community-based crisis team, again, that could be operated by fire, EMS, city, county, medical facility, or nonprofit crisis responder. It includes personnel employed by a BHA, so there may be a contracting of those organizations with a BHA to provide the behavioral health clinician role within those teams, and can consist of behavioral health staff and medical staff. And I did see a question pop up here. Does MRRCT replace MCAT? Great question, Gail. We have a lot of acronyms for a lot of different teams that operate within our regional service area, and MCAT is one of our mobile teams that respond. So it doesn't necessarily replace MCAT, but what MCAT is providing is mobile rapid response crisis. So if that helps kind of clarify that, we used to just refer to mobile crisis as MCR, mobile crisis response, and now the state has kind of given it this new designation of mobile rapid response crisis and crisis teams. And so it is the overarching service that's being provided, though we may have different teams locally name different things, but they're providing that service. I hope that helps clarify. Clear as mud sometimes. Next slide, please, Jessica. And lastly, but not leastly, some place to go. This is also something that we provided an update on at our last crisis collaborative, but helpful to also refresh as we look at building out that continuum of crisis services. And so there was a new designation developed 2 years ago and then updated again last legislative session for crisis relief centers, which is 23-hour observation. Spokane County has committed opioid settlement funds and is underway in building out a crisis relief and sobering center to provide services. And this will be for 18 or older at this point in time, though there was the last legislative session, not this one, but the one prior, did allow for crisis relief centers to be established for youth services. And there's still a lot of working out the DOH rules associated with that. So at this point in time, we're just focusing on 18 and above. And this center will allow for a greater continuum of those crisis services. So as Haley, Joe, and Tennille talked about the Spokane Regional Stabilization Center, this Crisis Relief and Sobering Center will be co-located on that campus. And actually, I'm happy to provide information that there was an RFP that went out for a provider for the service of this Crisis Relief and Sobering Center, and Pioneer Human Services was the identified and selected provider of that service. And so they will be looking to work with us as we build out this facility. This facility will allow for several different things, triaging and initial screening of individuals as they come into the service. This center will allow for individuals to walk in to receive those services, for law enforcement and emergency responders to drop off individuals, with the hopes of diverting them from the criminal legal system or hospital ERs if they don't need that level of care. As well as if MOUs are established, there's provisions in the statute that allow for hospitals to do transfers to this facility as well. It will provide crisis relief services under that 23-hour crisis observation. It will also allow for sobering. We are pairing sobering with that as we recognize the need within our community. There is some minor physical wound care and assessment that can be completed under the statute for this crisis relief component, as well as care coordination. So taking away some of that component of medical necessity, allowing individuals to walk in, be assessed, and be coordinated to appropriate care, whether that be being able to address that crisis there in that center, whether that be, needing to transition to a higher level of care, whether that be stabilization, ENT, swims, withdrawal management, whatever that may be, and helping coordinate that in a safe location that doesn't involve someone having to go to an emergency room or having to have criminal legal involvement. So that is the goal. The goal for the facility is to be open and operational in early 2027. We're under the building design and planning phase right now. And so there will be many more updates to come as it pertains to this, but something that we're looking forward to having within our regional service area as an access point for individuals. And here's our contact information and just a little bit more about these dispatch protocols. The intent is for these to be developed and submitted to the healthcare authority, and then upon approval, they'll be provided to the Department of Health, the authority, which is the healthcare authority, and the state 911 coordination offices. And they will be updated as needed or no later than 3 years. So we will continue to update those as there's updates to our crisis system of care. Again, it's meant to kind of give an overarching picture as well as some workflow and streams on how that operates to get everyone into alignment with so many different entities involved within that crisis system and so many changes that have occurred within the last several years. So I'm going to stop talking and open it up for questions, comments from the group. If you have any, you don't have to.
A lot of good information you shared. That's what I have to say.
Thanks, Gail.
I was just wondering, Ashley, do we have any of the community mobile responders?
The CBCTs?
Yeah.
No, we
In
don't. We
Spokane?
don't have any endorsed teams at this point in time, and we don't have any applications submitted for the community-based crisis teams.
Okay, thanks. I was just curious.
Yeah, no, good question. I think there's still a lot more to learn from that part of our crisis system as it's newly implemented. So, and Dave Crump, yes, we can send these slides out. And of course, if you have questions or input, please feel free to send that to myself or Keelan or Jessica or any member of our team. We're all pretty involved in all of those things going on currently. Arlia, do you want to pull up the agenda again, please? I will call out before we jump into provider updates and community highlights that our next meeting, we are planning for June. The date should be set here soon, and we'll send that out to the group here. And what we plan to do is kind of co-opt our crisis collaborative for a regional crisis continuum of care forum. So similar to kind of an overview of our crisis system, but the goal of this crisis forum is to also to bring together our stakeholder group involved within that crisis system to identify, what's going well, what are some barriers that we're experiencing, and kind of help highlight those and report those back to the state and advocate for our region for the needs as it pertains to our system of care, our crisis system of care. And so that date will be forthcoming, and that's our intention for the June meeting, is to have more of a focus on our crisis continuum of care in that regard. So just want to plug that, tell your friends, and we'll get information out to you guys shortly on that. And now I'm going to turn it back over to Kaylin.
So thank you, Ashley. So yeah, we have about 10 minutes left. So our next agenda item is where we open it up for any walk-on items or provider updates, community highlights. If there's any additional agenda items that people want to discuss, feel free to speak up.
Hi everyone, Drew Comito with Excelsior. Just a quick update for y'all. We just wrapped up, we do camps for youth. And so we just wrapped up a spring camp and we're going to be gearing up for registrations in the next month or so for summer. So if you or any staff are interested in participating in like a summer camp that's designed for youth who have some challenges in behavioral health, mental health needs, we do have a mental health clinician who's on site during the time working with them. We have certified rec therapists who are nationally certified, and they come, they hang out on our 40 acres and they do challenge course and pool time. They get breakfast and lunch and all that. So it's free to the youth. They do have to have a mental health diagnosis with it, but we assess for that. And it really helps give some respite for caregivers and things like that in the summertime. So if you want more information about that, feel free to email me. That team can come out and do a presentation for anyone or talk to you about what that might look like.
Excellent. Thank you, Drew, for that, sharing that resource. And if you want to drop your email in the chat, that would be helpful. Any other topics, shout outs?
I'll take a second here. This is Tara, Alliance up in Stevens County. Can you see me?
Yeah, we can see it. You're a little bit quiet. I'm not sure if you're able to speak up.
Yeah, I'll sit closer to my microphone. Just a really brief update. I arrived at this meeting very late and I apologize for that. So it may have already been addressed, but Stevens County is able to proceed with our own licensed stabilization facility. The court case is completed and we're going to proceed with building and pursuing certification for a licensed crisis stabilization facility up here.
Excellent. And is that, Tara, is that going to be 10, 16 beds? Do you know?
It's 14.
14 beds.
Yep, 14 beds.
Excellent news. Any other provider updates? Going once, going twice, not hearing anything. Okay, well, I think with that, we'll go ahead and wrap up the meeting. As Ashley mentioned, our next meeting will be co-opted with the Crisis Continuum Care Forum sometime in June. So stay tuned for that. And thank you again for our presenters, Tennille, Haley, Joe, for joining us. And hope everybody have a good rest of your week. Thanks, everyone.
Thanks for having us. Have a great day.
Thank you.
Thank you.
Thank you.